Ethiopia is now facing one of the deadliest viral threats known to modern medicine, a virus with a fatality rate as high as 88%, a virus with no approved treatment, a virus that has sparked fear across Africa for decades. For the first time in history, Marburg virus disease has been confirmed in Ethiopia. Today, we break down what's happening, how dangerous this outbreak is, why it matters now, and the critical weeks ahead that could decide the country's fate. In mid-November, Ethiopian health authorities detected 8 suspected cases of viral hemorrhagic fever in the South Ethiopia region. Within days, laboratory tests confirmed the worst-case scenario: Marburg virus disease. The Ministry of Health quickly reported 12 confirmed cases, 8 deaths, hundreds of contacts under monitoring, 2 patients recovered, several still under treatment. This is Ethiopia's first ever Marburg outbreak, making it one of the most serious health events the country has faced in years. The World Health Organization immediately deployed teams of experts, specialists in outbreak response, laboratory diagnostics, infection control, and surveillance. They also released $300,000 in emergency funding, along with isolation tents, personal protective equipment, and testing kits. International cooperation ramped up fast. Russia's public health agency even developed a highly sensitive diagnostic test specifically to help Ethiopia contain the outbreak. But despite these efforts, the situation is extremely fragile. Marburg virus disease belongs to the same family as Ebola. It spreads through direct contact with bodily fluids, contaminated surfaces, or infected animals, especially fruit bats. Symptoms appear suddenly: high fever, severe headache, vomiting, abdominal pain, diarrhea, followed by internal and external bleeding, and in severe cases, multi-organ failure. There are no approved vaccines, no antiviral medications. Treatment is limited to hydration and supportive care. And the numbers are brutal. Average fatality rate, 50%. Past outbreaks, 24 to 88% mortality depending on the health system. Once community transmission begins, stopping the virus becomes extremely difficult. By late November, Ethiopia had 73 suspected cases tested, 349 people identified as contacts, hundreds still under observation. Some communities are remote with limited access to health care. Some regions have health centers damaged by conflict, and some places are dealing with power interruptions, shortages of staff, and limited testing capabilities. This outbreak isn't happening in isolation. Ethiopia has been battling cholera, measles, dengue fever, and massive humanitarian challenges. Now, Marburg adds a new deadly layer. Across Africa, similar crises are unfolding. Namibia battling Crimean Congo hemorrhagic fever. The continent experiencing its worst cholera surge in 25 years, and health systems stretched thin everywhere from Mozambique to Nigeria. The pressure is enormous, and Ethiopia's outbreak is happening at the worst possible time. One of the most unique parts of Ethiopia's response is the involvement of religious leaders. The Ministry of Health has called on priests, pastors, religious teachers, congregation leaders to help raise awareness and prevent spread. In Ethiopia, religious institutions are deeply connected with local communities. Their involvement can reach places where health workers cannot. Religious leaders have pledged to educate believers, promote hygiene practices, prevent misinformation, and support isolation guidelines. This level of community engagement is crucial. Past outbreaks in Uganda, Angola, Tanzania, and Equatorial Guinea proved that public cooperation can make or break containment efforts. Health officials are racing against time. Emergency isolation units have been set up.
Travel screening at airports and border crossings has intensified. Medical teams have been trained and deployed. Supplies are being distributed rapidly. But the challenges are serious. Many contacts live in remote villages. Testing capacity is limited. Symptoms often resemble malaria or typhoid early on. Fear and misinformation may push patients to hide symptoms. If the virus spreads beyond the initial region and reaches dense urban centers like Hawassa or Addis Ababa, the situation could escalate dramatically. Experts warn the next few weeks are critical. If new confirmed cases emerge among the monitored contacts, Ethiopia could face a much larger outbreak. If not, the country may manage to contain Marburg before it becomes a national or regional crisis. Marburg was first identified in 1967 after outbreaks in Germany and Serbia linked to African green monkeys imported from Uganda. Since then, it has appeared sporadically across Africa. Angola, 2005, one of the deadliest outbreaks. Uganda, 2017-2018. Ghana, 2022. Equatorial Guinea and Tanzania, 2023. Rwanda, 2024. Each outbreak reinforces one truth. Marburg spreads fast, kills fast, and demands fast response. Its unpredictability and similarity to Ebola make it one of the most feared viruses in global health. Ethiopia's first encounter with the Marburg virus is happening at one of the most challenging moments for the country's public health system. The nation is already battling cholera, measles, dengue, malnutrition, and conflict-related disruptions, all of which stretch resources thin and weaken the ability to respond quickly to new threats. In many ways, this outbreak is not just a health crisis, it's a test of resilience. And yet, despite the grim numbers and the high fatality rate, there are reasons to stay cautiously hopeful. International support is accelerating. The World Health Organization has mobilized emergency funds, deployed technical officers with hands-on experience in viral hemorrhagic fevers, and continues to send supplies, from protective gear to rapid diagnostic kits. Other countries, including those that have dealt with Marburg before, are sharing expertise, protocols, and laboratory capabilities. That kind of cooperation can significantly slow the spread of a virus like this. On the ground, WHO experts and Ethiopian health workers are working side by side, tracking contacts, strengthening isolation units, conducting community outreach, and trying to stabilize the areas hit hardest. These early steps matter. In past outbreaks in Uganda and Angola, early case detection and rapid isolation were the difference between a localized flare and a widespread catastrophe. Will this outbreak remain contained in a few communities, or will it escalate into a national public health emergency? The next few days and weeks will be decisive. Testing, surveillance, travel screening, public cooperation, and rapid treatment will determine Ethiopia's path forward. What happens now will not only shape this outbreak, but may redefine how the country prepares for future epidemics in an increasingly unpredictable world. Whatever direction this crisis takes, we will continue tracking every update, every development, and every breakthrough.